This interview is brought to you by NTT Data. Federal health agencies work tirelessly to protect us from health and safety threats that arise at home and abroad, so we work tirelessly to bring them reliable, cutting-edge IT to improve productivity, leverage data, and save lives. As a top 10 IT service provider, NTT Data can help your agency put modern IT solutions into motion with our proven end-to-end practices, platforms, and services. Together, we can streamline government operations, implement AI successfully and responsibly, and improve public trust. Visit nttdata.com.
For over 30 years, HL7 International, or HL7, has worked with more than 1,600 members from the public and private sectors from over 50 countries to provide a comprehensive framework and related standards for electronic health information. I'm Sylvia Oakland, staff writer with GovCIO Media and Research, and I'm joined by Diego Kaminker, the Deputy Chief Standards Implementation Officer at HL7 International. Diego, thank you so much for joining me here at HIMSS 25.
Thank you very much, and thank you for spelling my name correctly.
You're so
It doesn't happen
welcome.
all the time.
I understand. People sometimes...
I'm very happy now.
Good. Then this interview is off to a very good start.
Yes, indeed.
I'd love to start by talking about the HL7 International 3-year plan. From 2022 to 2024, there were 10 strategic goals that you all were focusing on. And so I was wondering if you could kind of tell our audience where you all are at with those strategic goals.
Number one, leverage our accelerator program. You know that we have, for some years, something called, some organizations inside of HL7 called accelerators. An accelerator is a group of people and organizations that want to solve a problem in the healthcare domain using FHIR, because that's our flagship standard. So they want to use FHIR for something, and FHIR is an API framework. So they will use APIs to connect their systems for something. And each accelerator has a different domain and a set of use cases. Like, for instance, the Da Vinci accelerator covers interactions between patient, providers, and payers, or providers and payers, or patients and that triangle. CARIN covers consumer to provider, consumer to payer exchanges. Argonaut covers patient access and other technologies. But remember, always creating APIs for specific domains. Ilios covers public health. Vulcan covers research and the relationship between research and clinical workflow. So how to extract data from a clinical normal workflow for research. That's called real-world data. So every accelerator covers a different part of healthcare or of the domain. And what we wanted in our first goal is to leverage that and maybe have order and have the same rules for all the accelerators and create new accelerators. And what I can tell you about that is that we are announcing this year a new accelerator called the Device Accelerator. And it will talk about how you connect with your devices, your personal devices or devices inside of the hospital, and how can we manage to create the same framework for everyone to connect. Our education programs need to be enlarged, so to cover more people, to be better, and to scale. So those were our 3 goals with that strategy. So we created a credentialing program, and we have 2 new tests covered by that credentialing program. We created a partnering program, and we have 4 new partners between universities and companies, and we created a certified educator program. So if you teach about FHIR or other standards, we know that you are a good teacher and you have some certain level of confidence on your performance. So that's our advance on that strategy. Our third strategy is the Foundry. We create a sandbox for anyone to discover our implementation guides and reference implementations of those implementation guides, and a place to test them. So if you don't know how genomics work in HL7, you can just press a button, and as a customer, as a clinician, as a patient, you can see how it works, what kind of information they exchange and when. Wow. Because that's an API. when do I exchange information, what's the format of the information, and how can I see the information and when it's exchanged, so that you can experience that in real life. That's the foundry. Another one was global outreach. Increase our global outreach. And we increased our global outreach by new partnerships, because in some countries they are very small to have a full affiliate. We have affiliates in several countries. But in poor countries or small countries, they don't have the critical mass to have our own affiliate. We need to provide global standards. And in order to provide global, we need to hear them.
Yeah.
Have direct relationship.
You have to be on the ground and really understand.
We need to be or have people on the ground, because we cannot be everywhere.
Before we started talking, you had just gotten done with your session discussing CMS's Interoperability and Prior Authorization Final Rule, or CMS-0057-F. Lots of stuff going on there. So what does this final rule kind of mean for interoperability and efficiency?
Well, it expands what was in regulation before, and it expands to maybe actors that wasn't included in regulation before, because mostly regulation was about providers and what providers should do for patients. And the first one was give patient access to their data. So if you're a patient and you want to know what allergies are recorded or what labs are recorded, you can use your phone, your iPhone, for instance, and connect to your hospital very easily and see your data. That's patient access. It was about a specific set of implementation guides called burden reduction prior authorization. 4 words: burden reduction. Who is being burdened? The clinician and his team. And prior authorization, because that's one of the worst parts, is the clinician orders something, and then the patient goes to the payer and they say, no, you cannot do that. You need to bring this form and this form and this. Oh, so I go back to my clinician, and the clinician group will fill all the forms, and I will go back to my payer or fax it, and they will tell, yes, but something else is missing. That burden on the patient and on the clinician. How we solve that using APIs. And the solution they found was, whenever you are ordering something as a clinician, you can ask the payer, I have this patient, I'm ordering this. Is prior authorization needed? Yes or no? If yes, what do I need to fill? You need to fill this form, and this form. And there's a way to extract the information directly from the EHR without you typing anything. So most of the information can be pre-populated before sending it to the payer. That's burden reduction. Burden reduction for prior authorization. And finally, when everything is together, I have all the documentation, I can just send the prior authorization request just in the moment I'm creating the order. So when the patient goes to get the service that we requested, nothing needs to be done. That's the overarching idea. Yeah. That's burden reduction.
I was going to say, that sounds like an ideal situation for when I'm going to go get my medications after I go for my annual physicals.
That's the
even
idea.
Just going in for a regular sinus infection to get
for
what I
anything.
need. That is truly incredible, and I know.
I think that one of the other trends is that less things will require prior authorization. But for the things that really require, because there is some auditing needs or some set of steps before ordering something very expensive, we will demo in how to use the Foundry to try and test these implementation guides, how someone can relate as a clinician with this workflow. Because you need to assess how it will impact your work. So you can try it hands-on.
So where do you see emerging technologies like AI playing a role in interoperability?
There are several roles. One is, how do we know that something was created by AI and not by a person? And if it was created by AI, which AI? So that's one of the things that we are discussing, how to tag information and represent this, that it was created by AI and which AI. The other one thing we are doing is trying to classify the AI devices and describe them in a standardized way so you know that you are using this kind of AI with this kind of bias or whatever can be declared. And the other ones are more advanced in the sense that maybe you can have just anything, any text, any unstructured information, and you can ask AI to create an interoperable artifact, like a resource, a patient resource, recognition resource, and that kind of work, and it's working. Maybe 2 years ago we said, no, it's not working at all, but now it's improving a lot.
Wow, in just 2 years.
Yes, in the last year, maybe. So that's one of the use cases. Some people says, we don't even need standard, we can just put AI to read some artifact, some group of bytes, and speed whatever we want, maybe in our own format. But I don't think we are there yet, and it's very expensive. So mostly help us do our job, describe the information if it's being created by AI, and also I think our standard format translated into text in a standardized way. With that, we can create what we call RAG in AI, which is like a help to the AI to not hallucinate, because it will be circumscribed to this information about the patient, not whatever he thinks it can happen.
Right.
So the output will be more precise and less hallucinated. So that's another thing we are doing with our standards related to AI.
I'm really excited to see, everything that happens with AI and with interoperability. I've talked to so many people today who have said that it is going to be a journey, and it's not something that's going to happen overnight.
No,
so I appreciate all of the work that you and your team are doing, and thank you so much again, Diego, for joining us today.
And thank you very much for the interview.